And thanks, Dr. for the introduction, senior colleagues and as a nephrologist, physician per se, at least it's a bread and butter, and it is the most interesting part of one of the most interesting parts of our practice, especially so when we deal with immunosuppressants. So we will next 20-25 minutes we will see what the burden of antibiotic resistance, year and next year pathogens, and how the treatment, how the gram-negative resistant are treated. So, fine. As we know, it's a growing threat to public health and is increasingly common problem for acute care physicians to confront. Without effective antimicrobials, the success of modern medicine, treating major surgery, chemotherapy, all would be at an increased risk. And even from resistant strains, from multi-drug resistant to pan-resistant bacterial strains, especially common with a lack of availability of new antimicrobials that foretells a grave future. We saw in 2018 the microorganisms, which 16 were in the gram-negative category and only 4 from gram-negative organisms. So here we have one of those examples when you get such a and should be in panic when we get such a culture report from our microbiology labs. Around nearing 1 million people, and it kills more people than cancer and road traffic accidents coming together. Okay. Yeah. So, which of these antibiotics have an activity against neurally metaproteinases? That is ceftriaxone, avibactam, aztreonam, cefiderocol, meropenem, verbactam, and imipenem, cilastatin. So, with this question in the background, we'll go on to see this one of the vexing problems, that is burden of antibiotic resistance, MDR pathogen or XDR pathogens, and treatment for infections, both gram-negative and gram-positive. And as you see, it is a growing threat to the public health, an increasing common problem, and we are at loss for more effective antimicrobials in the which render many of our patients, especially those who post-op cancer chemotherapies, post-transplant at risk. And from XDR and MDR, we are going into pan-resistant bacterial strains, and especially the lack of availability of newer antimicrobials, it foretells a grave future. So this is one of the most, some of the clinicians can go into panic with this side of a report from a microbiology lab where it's resistant to everything from meropenem to doripenem to and ESBLs to aztreonam. So it kills quite badly with around 7 lakh people losing battle to this, with another 10 million projected to die by 2050, and especially with more than cancer and RTAs combined together. So will you define MDR? So it resistance to or agent in more than 3 classes of antibiotics. So then extensively drug resistance is resistance to an agent in all but 1 to 2 classes of antibiotics. And pan-drug resistant, where is resistant to all the classes of antibiotics. So what are the examples of multi-drug resistant organisms? So when we call a organism multi-drug resistant, we are referring to one of these groups mostly. So one is either extended spectrum beta-lactamase producing enterobacterials, and but it's resistant to most beta-lactam antibiotics, including penicillins, cephalosporins, and aztreonam. So they're commonly associated with additional resistance to fluoroquinolones and many other drug classes as well. And 13-20% of, especially 13.4% of hospital-acquired E. coli and 20% of CLEP infections are from ESBL producing organisms. Now the next is around the carbapenem. Next is what we are again worried is about the carbapenem resistant enterobacterials. So a significant we see a lot of carbapenem resistant enterobacterials now with the widespread use of carbapenems. So 8.7% of hospital-acquired CLEP pneumonia, CLEP infections, and 0.7% of E. coli, even more than that. So multi-drug resistance, Pseudomonas aeruginosa, where it's intrinsically resistant to many antibiotics, and additional resistance factors are common to the problem. So around 20% of these isolates are resistant to carbapenems. Again, another threatening infection is colistin-resistant E. coli. Although rare, plasmid-blown colistin resistance has been documented in E. coli, and it's often a drug of last resort for MDR gram-negative infections. And Acinetobacter baumannii, which is carbapenem resistant. It's intrinsically resistant to many antibiotics, and carbapenem is spread around bacteria with through mobile resistance elements. So carbapenem limited treatment options exist for carbapenem resistant strains. Again, the escape organisms contribute a major chunk of these infections, which are mostly XDR or MDR. E. coli, staph, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas, and Enterococcus. So there are, what are the common mechanisms of drug antibiotic resistance? Say there's inactivation of drug by enzymes like beta-lactamase. The activation of drug efflux pumps, where the drug is actively pushed out of the cell. It inhibits the drug uptake. The porins get blockage of porins or lesser expression of porins on the bacterial cell wall. The alteration of drug targets, all these, and plasmids confer resistance. So how we can treat the MDR organisms associated with there? So infections are associated with, as you saw, increased mortality, increase the length of stay in the hospital, increase healthcare costs significantly. So, and identify the appropriate antibiotics as early as possible before administration. The ICU might decrease the mortality, and several novel antibiotics has been approved in the past decade. So, what are the common, what we all use, and is beta-lactamase inhibitor combinations with either beta-lactamases or carbapenems. So, which are the inhibitors? One is clavulanate, sulbactam, tazobactam, avibactam, vaborbactam, and relebactam. They have intrinsic antibacterial activity by their own, but they inhibit a variety of number of plasmid-mediated beta-lactamases. So again, avibactam, vaborbactam, and relebactam inhibit chromosomally mediated AMZ beta-lactamases. And as you can see here, none of these inhibit the class B metallocarbapenemases, especially that includes the NDM, that is New-Delhi metallo-beta-lactamase, and which can combine these antibiotics, the resistant antibiotics, especially when you combine with ceftazidime, ampicillin, with clavulanate, sulbactam, piperacillin, tazobactam. They resist in antibiotics with an enhanced spectrum of activity against many organisms containing plasmid-mediated beta-lactamases. Similarly, when we combine avibactam to ceftazidime or vaborbactam to meropenem and relebactam to meropenem, they act against carbapenemases quite successfully. And because sulbactam and tazobactam inhibit the chromosomal beta-lactamase in bacteroids, they are effective against bacteroids infection as well. So coming to some of those drugs, ceftazidime tazobactam is a novel cephalosporin beta-lactamase inhibitor. It is effective against methicillin-sensitive staph aureus as well as Streptococcus species in the gram-positive group, and external spectrum beta-lactamase and multi-resistant Pseudomonas in the gram-negative group. And the approved indications are complicated urinary tract infections, complicated intra-abdominal infections, and hospital-acquired pneumonias. So this combination is fixed, is a fixed 2:1 ratio, exerts synergistic bacterial serial effects on susceptible bacterial strains. They directly inhibits the penicillin binding proteins, disrupts the cell wall synthesis and subsequently bacterial death. There's a greater affinity for PBPs when compared to ceftazidime alone or imipenem alone. So the addition to improves the spectrum of activity against resistant strains. And this results from tazobactam inhibiting B class A beta-lactamase in addition to a number of class C beta-lactamases. And third, it prevents the hydrolysis of ceftazidime and allows the enhanced spectrum of activity. This is, as you saw, this is one group where a combination of a beta-lactamase inhibitor with cephalosporin confers significant synergistic activity. It's one of the studies or aspect CUTI where it's used in the treatment of complicated UTIs, including pyelonephritis. is around large number of patients, cephalosporin tazobactam is compared with levofloxacin. And the primary endpoint was a composite of microbiological eradication and clinical cure. 5 to 9 days after treatment with microbiological intention to treat population with a non-inferiority margin of 10%. So it rapidly going through this, there are, I'll come to this slide again. So here the cephalosporin tazobactam led to better response than high-dose levofloxacin here in complicated lower urinary tract infections or pyelonephritis. So again, in intra-abdominal infections, so aspect UTI when used with metronidazole for complicated intra-abdominal infections, which is compared with meropenem. It is non-inferior to meropenem in adult patients with complicated intra-abdominal infections, including MDR pathogens. So as the earlier slide, so compared combining both together, the cephalosporin tazobactam combination has around 91% efficacy in E. coli, 84 to almost 10% efficacy in Kleb pneumonia, and 86 to 100% efficacy with Pseudomonas aeruginosa. Quite comparable with meropenem and better than levofloxacin. Then side effect profile does not differ greatly from other beta-lactams, and relatively mild nausea, vomiting, and diarrhea. But then carries a risk of seizures and Clostridium difficile associated diarrhea. So they should generally be reserved for MDR, Pseudomonas aeruginosa infections. So also indicated for UTIs, intra-abdominal infections, complicated and hospital-acquired pneumonias. There's been instances of bacteremia, bone joint and wound infections. So they can be considered using as a carbapenem sparing treatment option if there's a confirmed ESBL infection. So what next is ceftazidime avibactam. Quite we are it has been quite all of us are familiar about this drug, which has been the use is increased and probably with the disc and sensitive disc available quite commonly now. It's a novel cephalosporin beta-lactamase inhibitor. The coverage basic is against external spectrum beta-lactamase, including KPCs, OXA 48 carbapenemases, MDR pseudoaeruginosa, MDR acinetobacter. And the indications are complicated urinary tract infections, intra-abdominal infections, and pneumonias. So the activity of avibactam, it can inhibit class A and class C serum beta-lactamases, and partially the class D serum beta-lactamases, while there is no action against a class B, the zinc beta-lactamases, there is no action against including neutral metalloproteinase. When you have you're suspecting a class B beta-lactamase producing organism, but to this there is no you cannot use ceftazidime avibactam alone. So what is the rationale for this combination? So ceftazidime exerts its antibacterial effect in binding to a transpeptidase, a critical enzyme in bacterial cell wall synthesis, and can be inactivated by AMC, ESBLs, and all carbapenemases. So when used in combination with avibactam, it regains activity especially against Klebsiella pneumonia carbapenemases, extended spectrum beta-lactamases, and OXA 48 producing organisms. So this is one of the trials where it is compared with meropenem. The group was hospitalized patients with intra-abdominal infection diagnosis requiring surgical intervention or a percutaneous drainage within 24 hours before or after randomization. So as you see here, it is non-inferior to meropenem in the treatment of intra-abdominal infections, complicated intra-abdominal infections, and efficacy is similar against infections caused by ceftazidime susceptible and ceftazidime resistant pathogens. So in the study were reproof study where it is compared with meropenem, where the clinical cure rates were per patient is favorable and provides it's proposed as an important treatment option in gram-negative pathogens. So it's an excellent agent for extended spectrum beta-lactamases as well as Klebsiella pneumonia carbapenemases or OXA 48. It lacks activity against metallo beta-lactamases, and It was worse in vitro activity against MDR Pseudomonas aeruginosa compared to Cephalosporin tazobactam and may not be the preferred agent when you treat Pseudomonas aeruginosa. So coming to the dose, they need a renal modification, and it's 1 gram or 5 gram 8th hourly. And when you come to cephalosporin active to 2 grams 8th hourly. So, and it has to be reduced as the GFR drops. So another combination is meropenem vaborbactam. There is a broad spectrum beta-lactam inhibitor that potently inhibits class A carbaminopenemesis. And vaborbactam reduces the minimum inhibitory concentration to meropenem. One of the last trials is Tango 2 randomized clinical trial where the monotherapy for infections associated with English clinical care decreased mortality and reduced nephrotoxicity compared with the best available treatments. Then one drug which can be efficacious or helpful and it's warranted to be used in these beta-lactamase combinations is aztreonam. So how does aztreonam help? It's a monocyclic beta-lactam antibiotic which in practice has been used for a long time. It's a good in vitro activity. It's majority of gram-negative and facultative bacteria, including enterobacteria in Pseudomonas, but virtually no activity against gram-positive organisms or anaerobes. And this is a drug which is not degraded by class B metallo-beta-lactamases. So when you use it except as avibactam, it can act against class B metallo-beta-lactamases, and the avibactam has a synergistic action with aztreonam. So, and is imipenem sulbactam, which or imipenem cilastatin sulbactam otherwise. So there's a significant gram-negative coverage rather than gram-positive coverage. Some of the most susceptible of organisms here, especially ESBL, Klebsiella, pneumonia, carbaminopenemesis, MDR Pseudomonas aeruginosa, and it's used in complicated urinary infections. And it's again being imipenem, it is cilastatin, it is a you have to have a renal dose adjustment significantly, and in many time it is not recommended unless there is a hemodialysis. So this is a summary of studies on imipenem with a beta-lactase inhibitor. So most of the trials have shown in the various infectious settings like intra-abdominal infections, urinary tract infections, pneumonia, so a favorable clinical response and a reduction in all-cause mortality. Other class of drugs, it is siderophore cephalosporins, which act through siderophores, and one of those is cefiderocol. It is a good gram-negative coverage, especially Pseudomonas, Acinetobacter baumannii, Streptococcus multifida, and ESBL. So, what I have here is compared to other organisms which has activity against only and see here it has it covers all ambular class beta-lactamases A, B, C, and D, and it covers Acinetobacter baumannii, Pseudomonas, Streptococcus multifida, lecithin, Enterobacteriales, and especially again the action against class B metallo-beta-lactamase is a unique characteristic. How does it work? It hijacks the bacterial ion transport machinery. It enters the cytoplasm and facilitates cell entry and enters the cytoplasm, achieve high periplasmic concentrations, inhibits the penicillin binding protein, and causes cell death. There are few studies which cause a small increase in mortality, so it is limited to severe urinary tract infections, and it is a dose. So 2 grams every 6 hours or 2 grams every 8 hours. 8 hourly is given in a normal renal function, and it requires a reduction with reduced GFR. And when somebody with end-stage renal disease, it's 0.75 milligram every 12 hours. So some of the unique therapies, I'll come to that later. So one of the again above compared to with gram-positive agents, we have a few molecules. One is the 5th generation cephalosporin ceftaroline. This is broad spectrum activity against gram-positive and gram-negative organisms, and with it can be used in those organisms, especially which are resistant staph aureus, especially MRSA and staph with reduced susceptibility to vancomycin inner solid. The dose is 600 milligram every 8 hours early and requires a renal modification. Daptomycin, again, is a cyclic lipopeptide with bactericidal activity of Staph, Streptococci, and Enterococci, including vancomycin-resistant Enterococci and MRSA. It has different mechanisms of action, including disruption of cell membrane function and inhibits protein, DNA, and RNA synthesis. And depending on the gravity of infection, the dose can be varies from 4 to 6 milligrams per kilogram per day. The other group of organs has lipoglucopeptides, which can actually replace vancomycin or teicoplanin in the action again in a situation where it's given against MRSA or other gram-positive organisms. There are dalbavancin, oritavancin, and telavancin, which are a longer duration of action and the non-inferior to vancomycin. Eclaprime is another parenteral agent with bactericidal activity against gram-positive bacteria, including MRSA. It inhibits dihydrofolate reductase, blocking a key step in thymidine synthesis. And most of these drugs are used for skin and soft tissue infections, acute bacterial infections you are resistant to, especially methicillin-resistant or even vanco-resistant Staphylococcus aureus. So there are a number of other therapies which has been tried. One is phage therapy, which recently tried again for Acinetobacter baumannii. It has been genetically engineered to selectively destroy the bacteria, but large clinical trials have not been shown other than small trials and anecdotal reports. So we have both pharmacodynamic, they may not be able to act against the bacteria in vivo mainly, and pharmacokinetic, how to deliver the phage to the organ where the bacteria is located. And again, the phages that deliver CRISPR-based Cas3 to the bacterial host, which irreparably shreds the bacterial DNA. So one of the non-antibiotic based newer therapies. So coming back to our original question, which is antibiotics? As we saw, near NDM1, the activity is limited either with aztreonam or cefiderocol, and most of the BLI inhibitors, they have no action against class B or zinc metalloproteinase group. So they are to summarize, there is a significant threat to public health, and acute care settings have an important role in limiting and adhering to antibiotic stewardship. They have an important role in treating MDR infections. The novel antibiotic provide options to therapy where none or few exist, and to really do prescribing quite judiciously to reduce resistance and degrade the future utility of antibiotics in treating MDR infections. So antibiotic stewardship programs to increase awareness of appropriate use and local antibiotic resistance patterns. And every 40 to 72 hours, the antibiotic therapy should be reviewed for clinical response, de-escalation, and or discontinue therapy. And familiarity with novel and recently approved antibiotics is imperative to appropriate treatment. Thank you.